Well, welcome everyone to this webinar by Alta Planning and Design. I am Don Kostelek, a Senior Associate with Alta, based in our Boise, Idaho office. And we wanted to bring together the group of panelists today to talk about the issues of health, equity, transportation, and planning integration, and what that means. What are the tools that we're employing for that, and what are some of the practices that are going on out there to integrate data into planning, to use health as an informant to a project, and to set up communities for better funding opportunities coming out of the health realm. We have a couple hundred people joining us today, and we'll give you some instructions when we get to the end on Q&A on how to ask questions for our panelists. So we will get that going. We have 3 presenters today to talk about a variety of projects that we've been working on as community partners with these entities, and we'll take you from South Carolina up to Minnesota and out here to where I am in Idaho. This will address those issues of health, equity, and transportation, and we'd love to get your thoughts at the end of maybe some of your practices or thoughts on this. Those of you that just returned from the National Planning Conference in New York, I'm sure you saw a lot of health themes in the presentations that you saw and just walking around that city. This slide here is from a 1930s children's book in New York City on the ABC of city planning. And it says simply, V is for value, not measured in wealth. Planners think wisely, weighing comfort and health. And if we think about where our profession came from, and even where our design professions, our engineers and our landscape architects, it was from many of the public health initiatives of the 1800s. So while we're here today in 2017 talk about integrating health into our professions, we're not really doing anything new. We're really going back to our roots. And if we think of some of the grand projects at integrating health into planning and design, we can go back about 130 years to Chicago and look at this image here, and you can see the person standing in the middle of it. This is the project that led to the reversal of flow of the Chicago River. The health conditions were such that human and animal waste and other city pollutants were flowing into the river, going out into Lake Michigan, going into the city's public water intake valves, coming back into the city, and people were drinking that water. We had such a massive public works project that we reversed the flow of the river in the name of public health. And back then, many of our cities were walkable, as walking was the primary mode of transportation. And I think we'd like to all go back to the day when our biggest public health risk related to walking was spitting on the sidewalks. And if we think about the fines levied at that time, the fine for spitting on a sidewalk was more than what a fine today is for not yielding to a pedestrian in a crosswalk. So where we're at today, as we had public health projects that reverse flows of rivers, we now struggle for people to get basic access to bus stops or basic walking access to their grocery stores that can come out of our planning and our public works desires. And just as the health issues of 100 years ago were dealing with communicable diseases, we now have chronic diseases that are our leading causes of death. And so now we'll find as we get into planning and talking about transportation and equity, we have issues of food access and food security that are now starting to bubble up. So as you think about your own professions, if you're a planner and you think of your zoning ordinance that says this shall be for public health, safety, and general welfare, or you're an engineer and first canon for the code of ethics is holding health paramount, let's think about how we can modernize that perspective on health and deal with the issues of today. We've addressed a lot of the basic clean water and sanitary sewer issues that led to a lot of our planning and design codes. So I challenge you to think about how we can modernize them today, and I hope these presentations spur some of that thought. Our presenters today come from the public health planning and design background. Chris Saliba is a senior associate with Alta's office in Seattle, and he will be our first presenter. Be followed by Kelly Cavanaugh with the South Carolina Department of Health and Environmental Control. and then we'll wrap up with Jean Mutchie, who is with St. Luke's Children's Hospital in the Boise, Idaho area, and we'll profile a project that we have been working on with them. The three projects that we're going to feature today really emanate from small town and medium-sized city efforts, and I think this is a great thing considering where much of the last 10 years have been. When we were dealing with data and practices early on, it was mainly the major metro areas that had more resources or more metro-based health departments. Well, now because of the tools available and the data that's starting to come about, we're able to do this in smaller cities. So we'll have examples from Rochester, Minnesota, and the Destination Medical Center City Loop, the South Carolina effort, which was statewide based on pedestrian planning, and a Nampa, Idaho healthy conditions assessment that is really a precursor to some of our traditional community planning efforts. So with that, we'll start with Chris Saliba and the Destination Medical Center effort. As I said, Chris is with Alta's office in Seattle. He has a background in both public health and landscape architecture. So a lot of the work he's done is integrating health metrics and health impacts into the design of projects. He looks at this through the lens of data analysis as well as elements of the built environment. So with that, Chris, take it away.
Thanks so much, Don. Good morning, everybody. As Don mentioned, I'm going to talk with you about the Destination Medical Center project that we're working on in Rochester, Minnesota. The Destination Medical Center project, also known as the DMC, is a development project that's been funded by the state of Minnesota, the city of Rochester, Olmsted County, and private investments. The project is about creating a place for residents and a destination for the 1.3 million visitors to Rochester in the Mayo Clinic every year. One of the key goals of the project is for Rochester to become the destination for health and wellness. There we go. As part of the DMC project, we are specifically, Alta, that is, we're working to design the City Loop, which is a signature walking and biking facility that encircles downtown Rochester and connects existing trail networks and destinations. So the conceptual layout of the City Loop is shown here in that orange dotted line. The loop is approximately 2 miles long, and the City Loop will provide connections to each of the DMC districts that are being developed. It ties visitors, residents, and workers to nature, culture, and entertainment throughout the city. So as a starting point in our process, working with engineers and other professionals on the project, just to kind of step back a little bit, the team is really big. There are a lot of consultants working on this project on different components of it. So as I mentioned, Alta is working on the City Loop piece. There are other consultants that are working on transit elements, parking, and the development and land use aspects of the project. So there's a lot of interaction with allied professionals in the planning and design industries. So given that we knew that people were coming from different points of views, we wanted to make sure that people on the project, and particularly the project leaders, were on the same page for understanding why this project was important from a health perspective. So to do this, we stepped back and we talked with planners and engineers about the 5 determinants of health as a starting point. Health folks are really familiar with these 5 elements, but maybe less so in the engineering and design professions. So we talked about the physical environment's impact on shaping health, individual behaviors, clinical care, biology and genetics, and the social and economic factors. And by doing this really helped us bring the project stakeholders and team members along in understanding how the built environment impacts health outcomes. And in particular, the 3 components or 3 elements that can have an impact on shaping population health outcomes. So in particular, looking at are how individual behaviors can increase physical activity, such as exercise, how the physical environment has a positive impact on improving air quality and noise, and then the social and economic factors, how the social determinants of health are focused on can be focused on improving access to food, access to healthcare, and access to open space. So we framed this point of view, and then we talked about, well, when we look at what can shape health, those the majority of those three conditions, those three elements that I just described, shape upwards of about 75% of population health outcomes. However, money, our financial investment is traditionally spent on clinical care and treatment. So there's a contrast here in terms of where significant impact can be made in preventing disease compared to where investments are traditionally made in treating illness. Then we talked and kind of framed the Dr. Friedman's health impact pyramid, and talking about, okay, understanding socioeconomic factors and how those socioeconomic factors can have a significant impact on population health outcomes. So on this triangle, that is the orange on the bottom. And as you move up that pyramid, the individual health outcomes are shaped more by those clinical interventions. And our work is really focused on changing the environmental context of communities to have a significant impact on health outcomes. So if we change the environmental context to make healthy options the default options, regardless of somebody's education, income, or other societal factors. So with that background, that primer that we were using to bring our project stakeholders on getting everybody on the same kind of level of understanding, we then used the 500 cities data point as a starting point in our process to understand the baseline health conditions within the city of Rochester. So to do this, we used as I mentioned, the CDC's 500 cities data set to examine rates of chronic disease and health behaviors at a neighborhood level. So a little bit of background for folks that might not be familiar with the 500 cities data set. This project, this data set was recently released in January of this year, excuse me. And it's a collaboration between the CDC Foundation, and the Robert Wood Johnson Foundation. And data is available for 27 health indicators via their interactive website. And it uses census tract data for the 500 largest cities in the United States. And so what's really nice about this data set is that data has traditionally only been available at a, say, state or county level. So now we're able to get at a census tract level to help us kind of understand and see more granular levels of detail of information at a neighborhood scale. What is captured in this 500 cities data is that about a third of our population in the United States resides within the cities. And the measures of the 500 city data set, as I mentioned, there's 27 health indicators, and there are 13 that look at health outcomes such as coronary heart disease, diabetes, 5 unhealthy behaviors, no leisure time activity, obesity, and then prevention practices such as health insurance coverage. So we use this data to map existing health conditions in the city of Rochester. First, we looked at coronary heart disease, which is the leading cause of death in the United States. The map itself, the red dashed line, indicates where the proposed city loop is located. The purple represents the city average rate of coronary heart disease, and the dark purple represents above average, and the light purple represents below average. Overall, we found that Rochester, there were higher rates of coronary heart disease compared to the state and national average. And in our communications with our stakeholders, and then specifically with public engagement, we provided this information, and then tied it back to how increasing physical activity can have a positive impact on coronary heart disease. That's some of the infographic and the data on the right. So bringing people along with helping them understand what's happening at a granular scale, and then bringing them along to make the connection between, okay, if we can increase physical activity, there can be positive impacts on coronary heart disease. We also looked at, we mapped the rates of mental health, the prevalence of obesity, and diabetes. So with this information about health conditions in Rochester, we then identified our targeted users of the City Loop and how to match the design concept to these users. So quickly, this is using Roger Geller's 4 typologies of the strong and fearless 1%, 1 to 3% of folks that would like that will ride anywhere, 5 to 10% of people that feel comfortable riding, and then the 50 to 60%. This is our target market. These are the folks that we want to get active. We feel like we believe that this is where we can have the most impact in being able to increase physical activity among the population and visitors. So we talked about mapping our data and mapping the rates of chronic disease in the city. We've then we're connecting that with, okay, who do we want to increase this for? Who do we want to increase physical activity for? And then we're moving into we're transitioning into the design concepts of looking at level of comfort. And our logic is that if we make the City Loop safe and comfortable for walking and biking, then more people will use it. It's a pretty simple approach here. And we use this level of comfort diagram to communicate on the left suitable facilities for all ages and abilities, and unsuitable on the left and suitable on the right. And talk through this spectrum of less to more. And as we work through that design process, honing in on if we want to increase physical activity for the most amount of people, we need to target that high suitability for an all ages and abilities facility. So that gold standard or high level of off-street pathway. We also looked at the level of stress to assess and understand the existing stress of facility types within the city itself. So this map is showing that the dark green are the most comfortable bicycle facilities that exist now for all ages and abilities. These routes are primarily all off-street trails. Light yellow represents somewhat comfortable, light green represents somewhat, yellow represents not very, and orange represents not at all. With that information, we used it to guide us in the development of our design concept. So we know that we want to increase physical activity in order to have a positive impact on the chronic diseases and in particular coronary heart disease that we talked about earlier. And we know that in order to get people moving and walking, then this facility needs to be safe and comfortable at the highest level. So we developed a concept called an elevated experience. And what that is focusing on creating physical separation through curb separated facility from the roadway. Our initial early design concepts, there's a couple that I want to talk you through. Here's a 100-foot right-of-way of an existing street section, and then we applied our separated elevated experience concept to this 100-foot right-of-way. We're able to achieve an 11-foot two-way bike facility with buffers between an enhanced sidewalk, as well as a thickened edge buffer between vehicular travel lanes. We also looked at a typical condition for a 66-foot right-of-way. Here you can see wide vehicle lanes, reasonable sidewalks, and then we applied the two-way protected bike lane in this condition. This is in a residential setting where there are significant existing trees. And so part of the goal here is that we also need to save and protect those trees, and how to integrate that into the overall design, as shown on the right side. So we're maintaining, here we have a 12-foot bikeway. We're using existing street trees to create a buffer between the bike facilities and the pedestrians. And then a 66-foot proposed solution in a more downtown setting. So the big difference here is that 2-foot buffer between bikeway and enhanced walkway is a more horizontal treatment. And then here's an example of an intersection that we're proposing. So as we've talked about the conceptual design of an elevated experience, we want to hold that elevated experience throughout the entire loop experience. So what that means is that you're not going up and down at intersections. So this is a plan view illustrating that at the intersection, we've created a raised crossing to maintain priority for people walking and biking across the roadway. So the overall benefits of integrating health into this project is that it's ultimately that we're planning for people to be physically active, and we're able to elevate and talk about that at a high level, and use data to build the rationale for why it's important. It helps us with project prioritization. And the design accountability. As we move through the design process, we will be faced with VE challenges, and it will help us strengthen our argument about who this facility is for and what the overall objectives are from a health perspective, and helping the project reach its ultimate goal of being a city of health and well-being. It allows us to coordinate our efforts with our allied disciplines, and it validates the investment that the city is making from a health perspective. So with that, I want to thank you for letting me talk about the project today, and I'm going to hand it back over to Don.
Thanks, Chris. So I hope you saw some of the values of taking this health data and using it to inform a project, especially in a realm where things in the design realm are so rapidly evolving that sometimes the design standards don't fit the need of the people. And I think that's what some of this evolution is starting to do, is make a more informed decision when we look at the conditions of those who are living and experiencing these streets. So we're going to turn it over now to Kelly Cavanaugh, who is the active living consultant with South Carolina Department of Health and Environmental Control. Kelly's responsible for a lot of the active living subject matter expertise and promoting walkable and equitable communities at the state level with South Carolina and their many state level partners. She has an MPH, public health degree in health promotion, education, and behavior from the University of South Carolina, and is a certified health education specialist. Kelly?
Great, thank you. So, hello, I am Kelly Cavanaugh, and I am the active living consultant for the South Carolina Department of Health and Environmental Control, which you may hear me refer to as DHEC in the presentation. So today I'm going to talk to you about our pedestrian planning project. The pedestrian planning project evolved from DHEC's previous efforts that aimed to promote active transportation and promote physical activity more broadly within the built environment. Therefore, in order to provide some context, I'm just going to take a moment to highlight two of these projects. These efforts began in 2013 when the Centers for Disease Control and Prevention provided funding for statewide activities that aim to prevent and control diabetes, heart disease, obesity, and associated risk factors, and also to promote school health. South Carolina was awarded funds to support a number of strategies which included the Healthy Comprehensive Planning Project and the Active Community Environments Project. So the goal of the South Carolina Healthy Comprehensive Planning Project was to integrate healthy eating and active living policy recommendations into county comprehensive plans. Through this effort, we developed the South Carolina Health and Planning Toolkit, which outlines 67 best practice indicators for healthy eating and active living. We then provided regional trainings and targeted technical assistance to counties to integrate policy recommendations into their county comprehensive plans. It was from this project that the South Carolina Health and Planning Advisory Committee was formed. The second project is the Active Community Environments Project. For this work, DHEC provided seed money to 6 communities to learn how they self-identify, plan for, and implement projects that aim to create a more active community environment. Projects range from pedestrian plans and intersection improvements to school safety and wayfinding signage. The lessons learned from this project are being used to develop a step-by-step guide for South Carolina communities on how to create their own active environments. So from the South Carolina Healthy Comprehensive Planning Project and through the South Carolina Health and Planning Advisory Committee, we began to engage partners statewide and started to gain a better understanding of the different types of plans that exist at the local level. Through the Active Community Environments Project, we realized that there was growing interest in communities who wanted a pedestrian plan, but that rural communities and communities most in need of a pedestrian plan typically could not afford to develop one and oftentimes could not compete with larger jurisdictions for resources. Therefore, in 2014, when CDC released a second grant specifically targeting local communities, we used this as an opportunity to expand our efforts and provide resources to those communities most in need. So since the grant is focused on local community efforts, specific communities needed to be identified. In South Carolina, we identified 15 communities among our 4 public health regions that had high rates of chronic diseases, specifically obesity, diabetes, heart disease, and stroke, and other health disparities. So once South Carolina was awarded funding, we branded our state effort as SC Phase, which stands for South Carolina Prevention and Health Across Systems and Environments. So this is a 4-year grant that aimed to prevent diabetes, heart disease, and stroke, and to reduce health disparities, specifically among adults. So the grant looks at population-wide approaches within 3 main areas of focus. The first are environmental systems. So there are 4 policy systems and environmental change strategies that address healthy eating and active living. These include pedestrian planning, worksite wellness, open community use, and the Healthy Corner Stores initiative. The second focus is the health systems intervention, which aims to increase the use and improve the quality of clinical interventions and other preventive services. And the last focus area are community clinical linkages, which ensures that people who are at risk of chronic diseases have access to resources and programs in helping to manage and prevent them. So this is looking at your national diabetes prevention programs. We also hired regional staff to implement these strategies and to help create synergy among the different strategies. So for example, with regards to pedestrian planning, we want to ensure that vulnerable populations can walk safely to services within a community. And this would include your Healthy Corner Stores that sell fresh produce, work sites who participate in the Working Well program, your national diabetes prevention centers, and to schools that practice open community use. So now that you know how the grant was developed and the different focus areas, I'll clarify the pedestrian planning strategy and how this was determined. So for each grant CDC releases, they predetermine broad strategies that states can choose from. These are typically based on national best practices. So in this case, the strategy was community design that encourages biking and walking. And from here, states can refine the scope based on what's realistic and what capacity they have to be able to implement and measure that strategy. So again, based on our previous efforts, we wanted to use this as an opportunity to develop pedestrian plans at the local level. However, as we began to move forward, we realized that in some of those 15 targeted counties, a municipal or county-wide pedestrian plan already existed. In some cases, the communities were trying to implement their plans, but were having trouble getting their first project off the ground. So in order to remain equitable to the number of plans per region, we didn't want to limit these communities. So therefore, we refined the strategies so that we could develop and or implement transportation plans that promote walking. The communities that focused on implementation would then receive a design plan for at least one project in their previously adopted pedestrian plan. So as we began to solidify our strategy, we also realized that in order to increase the number of pedestrian plans in the state, it would be a good idea to know how many plans we actually have. Therefore, while we were working to get the pedestrian planning project off the ground, we engaged our Health and Planning Advisory Committee to create and disseminate a survey for counties and municipalities. The survey asked if the jurisdictions had adopted a pedestrian plan, and if they hadn't, if that jurisdiction was interested in developing one within the next 5 years. This not only provided us with a baseline of adopted plans that existed in the state, but also identified potential communities that could use assistance as part of this pedestrian planning project. So the objective of the project is to develop and/or implement at least 16 plans, which equates to about 4 per region, by September of 2018. For each plan, we incorporated a couple of requirements. So the first is that every plan must address access to healthy foods. Through our Healthy Comprehensive Planning project, we were already tying healthy eating into our comprehensive planning efforts, and we knew how important it was to have safe pedestrian access to healthy foods, especially in our low-income areas. Therefore, we wanted to create synergy around this by ensuring that healthy food access is considered within all of DHEC's planning efforts when possible. Since one of the purposes of the grant is to address health equity, we also require that this be specifically addressed within each plan. From a health perspective, we know that African Americans tend to have higher rates of diabetes and that low-income populations have higher rates of health disparities. Low-income populations also tend to walk and bike out of necessity, but oftentimes underserved communities tend to have poor facilities connectivity. Therefore, we wanted to see where these individuals were living in relation to healthy food outlets and other community services so that we can improve safe pedestrian access between these areas. And lastly, we also require that technical trainings be conducted with each community to help build their capacity at the local level. So this would look different in each community, but some examples of previous trainings include how to conduct a walk audit and designing and engineering roads for safe pedestrian access. So after going through a formal grant agreement process, we ended up contracting with Alta Planning Design on this project. So I'm going to talk about this slide first. So I don't have time to show you a whole plan, but I do want to show you a few examples of how those requirements are being addressed in each of our plans. So the following example is from the city of Chester. And just as a background, Chester is a small city with about a population of about 5,600 people. It's about 67% African American and has a 24% unemployment rate. And about 40% of residents in the city of Chester live below the poverty level, which is more than double the state rate. So the map you see here is the equity analysis, and the areas in red have a higher concentration of vulnerable populations, while the areas in green indicate lower populations. And then the populations that were included are bulleted out in the methodology on the left. So it's a little hard to see, but this comes directly from the plan in Chester. So the populations that are included are senior populations, children, low-income households, households without access to a vehicle, households with limited English-speaking proficiency, households who receive SNAP benefits, and non-white households. Okay, now I'm going to go back to this map for a second. So in this map, you can see where the healthy food outlets are in relation to those vulnerable populations we just mentioned. The circles indicate a half-mile walkshed of the healthy food outlets, meaning that residents in those areas can walk to the store within 10 minutes or less. So as you see, most of the outlets tend to be on the outskirts of town and are not within a 10-mile walk area of high concentration of vulnerable populations. Let's see. Okay. So after analyzing all of the existing information as well as the public input from the community, Alta provided a series of network recommendations. So the image you see here shows a map of the proposed recommendations that were included in the plan. Alta also included more specific information for priority projects, which also included before and after photo rendering. And here you see those same recommendations overlaid with the equity map you saw earlier. As you can see, the majority of recommendations tend to fall in areas with high concentration of vulnerable populations, and especially along corridors that connect those populations to local services. You also notice quite a few improvements leading to the center of the map, which, if you recall from the healthy food access map, this is where the one healthy food outlet was in the downtown area within a half-mile walkshed. So within each plan are a list of both infrastructure and programmatic recommendations. Since implementing the infrastructure recommendations can take a long time, we use the programmatic recommendations to keep the community engaged in the process. This helps to keep the plan visible to the community and can help to provide momentum for implementing the rest of the plan. Our local DHEC staff are responsible for helping to implement these recommendations by connecting them with local stakeholders and organizations. So as you may recall, each community received a technical training as part of their plan. In Chester, a walk audit training was conducted, which was very successful. The participants were so engaged that during that same training, they created 3 task teams and began implementing the programmatic recommendations before their plan was even finalized. By the time that the plan was adopted, the community was already applying for a mini grant through the Close Bar Foundation to purchase wayfinding signage. Although they were not selected, the city saw how engaged this group was and the potential for the signage to help increase foot traffic to the local farmers market that they decided to fund the project themselves. So that was just one example from the pedestrian planning project. But to date, we have 8 plans so far that have completed. Of those 8 plans, we have 4 that are adopted. The remaining 4 are continuing to seek adoption. 3 of those counties are pursuing, have decided to adopt their pedestrian plan as part of their comprehensive plans. And then in one community, we have the plan has to be adopted by both the city and the county council. Currently, we have 4 design plans that are being developed. So again, these are communities where pedestrian plans have already been adopted, and they are receiving design plans for one priority project in their previously adopted plan. And lastly, we have 4 remaining communities that will be brought on in September. So in conclusion, this grant aims to prevent diabetes, heart disease, and stroke. And since physical activity is a risk factor for these conditions, we can help to reduce the burden of these chronic conditions by creating environments that support daily means of physical activity, which is what we're doing through our pedestrian planning project. This project also aims to reduce disparities among adults. By providing safe pedestrian access, not only can we facilitate opportunities for physical activity through active transportation, but we can also help to increase connectivity to daily activities and services to those who need it most. And lastly, while DHEC's initial projects allowed for us to connect with planners on a statewide level, the pedestrian planning project is allowing our regional staff to work more closely with planners at the local level. This has helped to build new relationships in our communities and has reaffirmed the value that local planners bring to the table and why we need to continue to engage them in our built environment efforts. So with that, I thank you very much for the opportunity for South Carolina to share our story with you all. If you're interested in learning more about any of our projects, feel free to contact me at the information provided here. So thank you.
Thank you, Kelly. I think a key lesson there is we don't have to go it alone as community planners and as city representatives. And the more we start to tell the story of health and how it relates to populations in need, we find other partners. We find people willing to fund different initiatives in our community, and we're seeing that a lot more. And this next example from Nampa, Idaho will show another feature in terms of how a city doesn't have to go it alone, and how an exercise kind of pre or forward of comprehensive planning or corridor planning is informing some different outcomes. And Jean Mutchie with St. Luke's Children's in Boise, Idaho is going to lead this presentation. Jean has been in the healthcare industry for more than 16 years and focuses on community health and health equity initiatives. With St. Luke's Children's, she's the head of a medically directed regional childhood obesity program that looks at things through the lens of social determinants of health and issues that drive poor health outcomes. So the Nampa Healthy Conditions Assessment used kind of a triangulation method of the data and the analysis you've seen an example of in the previous presentations combined with on-the-field assessment of conditions, both population and infrastructure-wise, as well as interviewing several dozen community stakeholders and nonprofit organizations to inform that. Jean?
Thanks, Don. Good morning. So I'll be the only, I think, non-planner, non-transportation person, so excuse me if some of what I talk about is a little bit different, but Nampa, Idaho is located west of Boise. It's a community of about 85,000 people, and it's recently been awarded an Invest Health grant through the Robert Wood Johnson Foundation and the Reinvest Fund. As that work was underway, there had been a previous grant to really look at childhood obesity issues that were impacting the kids in Nampa, but we really wanted to look at something that didn't just have a programmatic approach. So we had spoken with Alta, and the Healthy Conditions Assessment began, and it has been incredibly informative. So the process was collect, layer, and use the data. We had a lot of data that we sort of assumed, but really didn't have it all quantified and qualified. So with this process, we determined hotspots, and then there was field confirmation. So a lot of door-to-door interaction, surveying residents to really understand what was driving the vulnerability in those hotspotted areas. We also identified shareholders, interviewed those folks, and then there was finding those needs where we could find some rallying points. And then from that, bringing people together to problem solve and plan. And then also to look at what assets existed, how we better focused them to create more maximum impact. So the data was based off of the health inputs on this slide. So you can see the bright red areas are those that flagged as those census tracts with the highest areas of need. So that was based on age, the percent who didn't have a car, Hispanic population, percent living below poverty, SNAP users, the percent of high school graduation rate renter versus homeowner, grocery stores located in the area, variety of different things, unemployment rates, uninsured rates. So these two areas, Census Tract 201 and 202, flagged as the most vulnerable. So the data, as you can see here around transportation issues, is we have in Tract 201 a high number of individuals who are over the age of 65, but they don't have a car. High prevalence of folks who don't have a good transportation option. In 202, we have fewer people who are elderly, but still a relatively high rate of those who do not have a car. And then couple that with the Hispanic population, the prevalence in Tract 202, and then also the percent living below poverty. That has created some really challenging issues for people living in those areas. So as you can see here, again, the tract number 201 and 202 really is hotspotted in this particular area, which is located close to downtown, but it has some challenges because both of the areas are either in our designated floodway or floodplain. So there's compounding factors there. Our public transportation as a viable mode is really limited. For folks who are trying to get to the grocery store, this area, these two census tracts are in a food desert. It can be a 3-hour round trip just to go to the grocery store, the nearest which is more than a mile away. So when we look at the tract hotspot issues, Terry Riley, number 1 on this map, that's our federally qualified health center, and it's a long ways away. Lots of barriers for transportation for people to get the access to healthcare for many of the residents living in this area. Not very centrally located by walking, transit, or bicycling. We've got intersection issues with our library and downtown. The library is kind of one of our newer infrastructure pieces, but it's had a lot of different changes in the routing of traffic. And so there's been a lot of intersection changes. It's also not centrally located for most of the people to access. We have changes that need to be made to the timing of intersections too for crosswalks. Through this plan, that is kind of low-hanging fruit where the city is able to address that. Again, we have major access issues to any viable grocer. What we have in those neighborhoods is just one convenience store. So again, those folks really are struggling with access to basic needs, access to healthcare, transportation to and from an employer, and then also clearly access issues to healthy foods. So again, on the ground findings was the crosswalk timings were not adequately timed. The frequency of crosswalks are not adequate either. We have a lot of people who are trying to run across 5-lane roads, pushing baby strollers, limited bicycle facilities as well. That's not really a generally not a mode of transportation that a lot of people use regularly. There's also minimal green space in these areas. The parks that do exist are generally older, and a lot of the equipment is outdated. One of the schools really is the hot spot for the central green space, but again, it's the access options are not that great. So going back to even what Chris said earlier, the 7 dimensions of health assets, when we look at healthcare, healthcare really only accounts for about 10% of a person's total health. So we're trying from the hospital perspective to take a better look at what is driving poor health outcomes. From the childhood obesity issue that we're seeing, that prevalence is increasing, and especially in our Hispanic and Latino population. Our medical director says that she went to medical school to treat kids, but now she's treating kids with adult disease. So finding that much more challenging. We have kids who are being diagnosed with fatty liver disease at the age of 7. We're seeing really sick kids. But we also know that we treat them clinically, but then we're putting them back into environments that do not promote or support health. So when we look at those 7 dimensions of health assets and we look at our community, we do have interspersed areas where there are opportunities for people to get help and support, but again, not are all very centrally located. So again, the dimensions of health and wellness, when we look at physical, environmental, social, intellectual, spiritual, economic, and emotional, and then elements of a comp plan, land use, transportation, resources, economics, schools, parks, rec, open space, and cultural, they're all so intrinsically intertwined that we can't separate the two and continue to work disparately. We have to look at how all of these elements impact the health equity of the community. So when we looked at this approach with the health conditions assessment, what we wanted to do is really get specific, have a tactical approach, be really geographic and even neighborhood specific. And Nampa is a community where they really want to solve their own problems. So how could we come up with local solutions to the local problems that were resident and community driven? And as a resident of Nampa, I'm acutely aware that we really like to figure out how to solve these problems at the local level. So the big 4 themes that emerged from this health conditions assessment and also the Robert Wood Johnson Foundation and Past Health grant work is that there's a major imbalance in the housing spectrum. Again, that's impacted by the floodway and the floodplain, but these 2 census tracts primarily really struggle with affordable housing and then even just enough housing. There's a 2-year wait generally in our community for affordable housing. We also have the highest number of homeless students in the state per capita. We have generally by the end of the year, we have about 1,500 homeless students, so about 10% of our student population qualifies as homeless. And then we usually end up with about 200 unaccompanied youth. So those kids are just unattached to any parent or guardian. So the imbalance in the housing spectrum is a major issue. Lack of transportation, again, in these 2 census tracts specifically, really make these residents vulnerable to compounding social determinants that drive poor health outcomes. Food access, we have a farmer's market, but it's over the railroad tracks in our downtown area. So there's some access there for one of the census tracts, but again, still really hard to get there. And then Hispanic equity. In these census tracts, you saw that nearly 50% of census tract 202 is Hispanic or Latino, and they really struggle feeling that their voice is heard or that that the needs that they have specifically in that neighborhood are met or addressed by the city. There are transportation challenges in walking and bicycling. We have some schools that have bike racks outside and not one bike is ridden to school because there's no safe route for these kids to get there. You can also see in some of the pictures, sidewalks that are not appropriate for people to use with strollers. And then, these are right in their neighborhoods, so not very accommodating in many of those areas. You can see Tier 2 poorly marked crossings. And as we look at our streets, North Canyon and then North Sunset, you can see here that the speed limit in one is 20 miles per hour. Go to the next one over and it's 35. So same residential area, but 15 mile per hour difference in a neighborhood residential area where we need to have better consistency with safety priorities around transportation. So our overall transit score, looking at connectivity, access to jobs, and frequency of service, we score really low. We really have challenges that now this assessment is brought forward, and the city and our transit partners and our planners are all working to try to come up with some more viable solutions, especially for these most vulnerable communities in these census tracts. We also here have bus stops where there's really no crosswalk in the vicinity for a good stretch. So people are just running across those streets. But you can also see on one side, it's mostly storage units and industrial. The other side is the neighborhood. So not great areas, possibly for the best connectivity along that bus route. We also have severe food access challenges that I mentioned. This was the Paul's Market on the right-hand side. They had planned to remodel, but this particular store falls in the floodway, and so bringing that up to code was really very cost prohibitive, so they decided to close. And again, Friendly Fred's, this corner market, is really the only access to food in this community right now. We right now currently up in one of the more vulnerable areas too. There's a Maverick convenience store that really borders our freeway, and it again is a heavily traveled 5-lane road. They're also putting a school across the street here, so you have people trying to really manage getting their food source and getting to their education source on a very heavily traveled road, again with significant access issues. So from the healthy conditions assessment perspective, what it has allowed us is we all, as hospitals, do a community health needs assessment if you're a not-for-profit hospital, and it identified for us diabetes and obesity, access to healthcare and insurance, and then also mental health challenges are top priorities. What this has allowed us to do is become less programmatic and really get down to that neighborhood level, link arms with community members, and have resident-led coalitions really try to change what their community looks like in those areas that are challenging for them and creating vulnerabilities and disparities. But it allows us to have a conversation that's data-driven, data-informed, and then we can all link around the assets that exist that generally we all know are limited. We link our limited resources, get really strategic, and for us, when we're really looking at mitigating some of the sharp increase we're seeing in childhood obesity rates, it allows us to understand the built environment and the context in which these kids are returning to their neighborhoods that are not, again, supporting health and wellness. We can get a lot more specific around our non-clinical approaches to creating better health equity in our communities. Thank you.
Thank you, Jean. And I think an important piece of that is we have a lot of the good data at the census level and what Chris showed with 500 cities about where people are living. And now it's an evaluation of where do they go and how do they get there and what are the conditions on those routes that they get there. So with that, I believe the panel to the side allows you to ask some questions. I think our technical folks are going to walk you through how to do that or how to raise your hand if you have any questions.
You'll see on your GoToWebinar, on your panel, you'll see a little hand that you can click on to raise your hand, or you can type in a question within the chat window and it'll push to us. Yep.
This is Christo in the Portland office. What I always think about when I hear people talking about what we've just talked about in terms of health and equity, we're talking about how to make interventions. And I wonder about how development comes into play. That there's these communities that don't have grocery stores, they don't have all of the public infrastructure, and there's been a sense of a kind of lack of interest from the perspective of good grocery stores going to those communities because they don't see a viable market. What I'm seeing happening in the neighborhood I live in Portland, the Lentz neighborhood in outer southeast, is the requirement for there to be kind of government intervention of making investments that allow that kind of development to occur. It's not just happening as a result of the free market. So I'm wondering what you all think about how we work with private development. How do we encourage that?
Gene, do you want to take a first shot at that, given the issues with the grocery store buyouts in Nampa and Caldwell?
Sure. Again, I'm not a developer, planner, or anything, but we are really working on that piece, because that, I think, is, we've resoundingly heard from those residents that the access to healthy foods is their biggest issue. Because not only do they have an access issue, they have an income issue. Many of these people are living below poverty, so they have very limited resources to shop anyway. So if you put in sort of a great corner store, a lot of people in that neighborhood are saying that's not a viable solution for us because we can't afford to shop there. So we're really taking a broad look right now at what are those assets in our community that people really want to see come into their neighborhood. And again, letting the residents shape that context. We are working with some finance options with banks and credit unions to look at maybe bringing in a compost market that already exists in our community. It's a Hispanic store, but it offers a lot of the ethnic foods that the neighborhood residents really want. But again, we're in the floodway and the floodplain, so there's a lot of discussion with developers around, what is the viability of somebody coming in with, again, in a neighborhood where there's severe challenges. But we really are having to have the city lead on those conversations to maybe look at what incentives exist to have developers come in, and the use options for those developers. But then again, something that meets the residents' needs and they will utilize, because it is pretty easy for them to say we don't see a viable market. So again, it's challenging, but again, I think it takes everybody linking arms and having these conversations around what does development look like that residents would actually utilize. So not a great answer, but a lot of conversation around that, because that's probably one of the largest challenges that we're facing.
Okay, I have Judy Wallace. Judy, can you hear us?
Yes, I can hear you.
All right. Did you have a question? I see your hand was raised.
Well, I'd written one in. I guess you didn't see it. I was interested in South Carolina. Once they get a buy-in on the pedestrian plans, what sources are the funds to actually build those?
So once the plans are developed, Alta Planning in the back of the sheet, they do have some, they do outline some potential sources for funding. So if they know that there are certain grant calls for proposals that are going on nationally at the time, or more sustainable sources like looking at your capital sales improvement tax, like certain ones are outlined for communities based on what they think that community is actually eligible for. But through our active community environments project and some other projects that are going on here in the state, we do actually have a list of federal, state, and local sources that are available for South Carolina communities specifically. And so each of our communities will have access to that information. But again, a lot of that information aligns with what's already in their plans. And then to be able to use that, our region staff basically connect the recommendations with the local level planners. So they're working with planners, they're keeping in touch with the city administrators, but they're also working with groups like Eat Smart Move More chapters, and sometimes they get some grant funding as well. And so by being able to plug them into the system, they're able to identify communities when they become available, and then they connect those opportunities with the appropriate stakeholders at the local level.
Okay, thank you.
And Judy, good to hear your voice from far away and hear you again. A couple of examples that I think this deeper dive into health elements and making the case for these has yielded is in the health foundation or private foundation realm. And an example was doing a health impact assessment on a Greenway Corridor feasibility study and pedestrian plan in Robbinsville, North Carolina. 700 people, population there. But Bristol Myers Squibb Foundation, a pharmaceutical, was involved in the community to address diabetes. And upon doing the health impact assessment and taking a deeper dive, they committed $50,000 to the design of that project. So I think it's about, instead of just saying, these are healthy, here's why it's healthy, and here's the populations that need the intervention the most. And I think that's where some of the non-traditional sources are more willing to step up and help pay for some of this.
So this one's for Sue Shikazi. Can you provide a reference to the tool used for measuring level of traffic stress?
Who's best to address that, Chris?
Sure, I can talk about that. That is an analytic, part of our GIS analytics team. Part of what they're doing there is looking at the existing facility type, and it's based on the Mineta report, and assigning a level of stress based on its level of separation. So a facility that has the highest level of separation, existing facility, for example, it is separated from traffic, would have its highest level of, lowest level of stress. And then for example, a facility that is a shared lane or no facility at all would have the highest level of stress.
Okay, next question is by Carolina Rodriguez. Walking while poor tends to be viewed suspiciously. How does this planning process address this? Are you involving law enforcement?
I can address it on the Nampa side of things. And yeah, one of the things we found in that assessment was, one, the city police department did not have a traffic safety unit. They only had patrols. And that came up as a concern in terms of addressing yield compliance and other pedestrian safety issues, because there was not a unit of the police department out there to address that. It just kind of came as it could, but they were getting other calls and weren't able to focus on it. And as a result of this project, the mayor of Nampa announced in the state of the city that the next budget year they are funding a traffic safety unit to address those issues. So we felt that was a great success story there.
Okay. Next question is by Lorenzo Mel. Can someone elaborate on the intersect between VE and health benefits as a means of balancing the VE analysis? An example of tactics, language, evidence, etc.
Who wants to take a shot at that one?
If I'm understanding that correctly, I'm reading that as through the value engineering process, how are we holding people accountable? I don't know. I'm not quite sure what the question's exactly saying. But the point that I was making is that as we move through the construction documentation phases, from concept through 60%, 90% in bid documents, is that we have a way of holding our design accountable to its goals, and if those goals are compromised through those VE efforts, being able to point to whether or not we're achieving our objections and desired outcomes. You know, I think it's also sets the starting point of where we want to go and why we're setting those objectives. And as we move into the VE process, if we do need to, if there is a compromise in terms of reducing costs. So for example, if in the Rochester example, if the raised crosswalks were VE'd out, value engineered out, and we had to have a more traditional curb ramp down to grade and crossing, what would that look like in terms of compromising our goals of making sure that those crossings are safe? I think they can be safe, but it would allow us to have that conversation in that context. I hope that was helpful.
All right, next question is by... Oh, go ahead, Don.
Nope, go ahead.
Okay, next question is by Dina. Can Kelly share the point system methodology got hotspotting?
The methodology was actually developed by Alta Planning and Design. It's included in each of the plans. So I can take one of the plans that are available and send it to individuals, and it's outlined in there. But other than that, I personally don't have the information on the methodology. But it is outlined in the plan. So if you provide your contact information, I can make sure that we get you a copy of one of those plans.
There's several ways to go about doing it. One is using the census data that's available, that's pretty common, as well as what Chris outlined with the CDC's 500 cities data at the census tract level. And you can take a pretty straightforward approach and start to look at how they overlay and see which census tracts may flag as having conditions of concern. And in some cases, I've worked on projects where we've weighted them, for example, up in Alaska, where some of the metrics we have in the lower 48 might be a little different, and an Alaska Native population from a demographic analysis means something different than it might when we're looking at it here in the lower 48. So your local mileage may vary, as well as your local data availability. So I think we've lost about half the attendees, and I know you've committed 10 minutes more of your time than we asked for. So I think we will do one more question if there's one out there, and then bid you good day.
Okay, next one is from Kathy. This one's for Jean. What advice would you give a community with a nonprofit hospital to convince the hospital to get involved in these types of interventions? Was it simply seeing the data assessment that convinced your administration, or were there other important influences and considerations?
That's a great question. I think as we look at the shift to population health strategies, we know that the community health strategy has to support that work. So when we're looking at how we care for a defined population of people, again, if we're just looking at that clinically, if you have hospitals in your community who are just looking at that from a clinical approach, they're going to, again, be sending those populations that they're now looking and we're being reimbursed on outcomes. If we're sending them back into communities and neighborhoods that do not support health, it's a cost driver for us, because generally our outcomes are going to align with a lot of the environmental and social determinants that these residents are facing. So again, when we're looking at even at a population of kids, if they're going home to food insecurity, high levels of poverty, a built environment that does not support activity, and transportation barriers that are prohibiting access to even getting them to a primary care physician, we find oftentimes a lot of our kids who are not attached to a primary care provider live in these neighborhoods of high vulnerability. We clearly cannot move the needle on effectively moving populations of people into a healthier category if, again, the hour they spend with us clinically puts them back into a neighborhood where health equity is really really a risk factor for them. So I would encourage you to use the CHNA data that those hospitals are required to produce, and really look at all of those social determinants that impact their health priorities as a conversation primer. For us, we're taking on a full community health strategy because we know, again, we cannot move populations of health, the population of people that we're responsible for and accountable for, if, again, the community does not support those health equity issues that we're trying to mitigate clinically. I hope that answers that, but again, I think the short roundabout is use their community health needs assessment data and partner with them. Find those points of intersection where the data supports going into neighborhoods and addressing the social determinants that are driving poor health equity.
Thanks, Jean. And with that, from wherever you're sitting, you can give our panelists a silent round of applause since we can't hear it on your end. But again, thank you very much for your time, and we look forward to hearing from you about your success stories in this realm.